Some basic anatomy. These are Frank Netter drawings. He's one I admire, one of the medical illustrators that helped me through school. But as we're familiar, we've talked quite a bit about the anterior circulation. This, of course, looking from the undersurface of the brain, is the middle cerebral artery. You'll notice on this M1 segment, the thalamus or the lenticulostriate arteries, which supply the basal ganglia. This is why I want you to focus on the conspicuity and the borders of the basal ganglia when you're looking at imaging of a patient who has symptoms suggestive of a stroke. Because the blurring of the basal ganglia are a result of impaired flow through these lenticulostriate arteries. These are the lateral lenticulostriate arteries. I also mentioned that the reason that the inferior head of the caudate is involved in occlusion of the carotid artery rather than the MCA is because the recurrent artery of Huebner, which comes off of the A1 segment, that's involved when you have a carotid occlusion, where that is spared when you have an MCA occlusion. So again, just to review that anterior circulation anatomy. Today, I want to talk about the posterior circulation anatomy. So again, we have the two vertebral arteries giving off the pica branches. The pica always comes off the vertebral before the confluence. Here, the vertebral arteries join, and this would be the anterior inferior branch of the basilar artery. These are often asymmetric and often asymmetric in sort of a logical way where we may have a big pica on one side and a big aica on the other side with a small pica. So these often balance out. This is the superior cerebellar artery. So again, the pica and the superior cerebellar artery cover the hemispheres of the cerebellum. And then above this is going to be the third nerve coming across here in between the third nerve and the posterior cerebral artery. The posterior cerebral artery here is the terminal branch of the basilar artery, forming this V at the confluence. There are small branches that come off of the proximal posterior cerebral artery. These are the thalamoperforators, which is why we see thalamic infarcts in posterior circulation ischemia. These are the pontine perforators. You see they're paired. They're not always symmetric, but this is why occlusions of these pontine perforators spare the midline. So again, I'm going to go through that sort of representations in patients who have scans, but I want you to sort of start with this anatomy, which is essential. Here's a surface model of the posterior circulation. Again, vertebral arteries, pica. This is a pica aneurysm. They often arise at the origin of the pica. This is going to be the anterior inferior cerebellar artery. And well seen here is the posterior cerebral artery, which is going to be above the tentorium. These are some of the classic posterior circulation ischemia syndromes. I'm not going to go through these at great length, but in terms of this concept of the proximal and middle portions of the posterior circulation, we have basilar artery occlusion, which will give often unilateral limb weakness, dizziness, double vision. Pica and vertebral lateral medullary syndrome. I'm sure you've all heard of these. And these patients have decreased pain and temperature in ipsilateral face and contralateral trunk and limbs. So lateral medullary syndrome, basilar artery occlusion, vertebrobasilar syndrome. These are patients with impaired flow, and this is dizziness, nausea, and vomiting. So these are the syndromes that are associated with posterior circulation ischemia, but we're going to focus on the imaging. Now, I'm going to start with this concept that you need to recognize at the outset. It is difficult to establish the presence of a posterior circulation infarct, and there are several reasons for that. Number one, CT imaging is often useless or misleading. So because of the beam hardening artifact that crosses the pons, it can be very difficult to identify a pontine perforator infarct on CT imaging. That's not just in the acute phase, that can be at multiple phases in the infarct. The other reason is that complex patterns of infarction are common. And so unlike the intercirculation, oftentimes the symptoms don't direct you to a single lesion. The other reason is these can appear in young patients with no vascular risk factors. These are the patients with vertebral dissections. These often go undetected, both clinically and on imaging. And finally, the MR findings can be subtle in the acute phase. So let's begin with this case here. This is a diffusion weighted scan. We're going from inferior to superior. You'll notice on the diffusion weighted imaging, we have multiple lesions here in the cerebellum. We also have involvement of the occipital lobes. As we go farther forward, this is a typical pontine perforator infarct. You see that it adheres to this unilaterality, and so there's sparing of the contralateral or the opposite portion of the belly of the pons. So again, this is a classic perforator infarct. So now we see we have occipital infarcts, cerebellar infarcts, pontine perforator infarct. We have an infarct of the cerebral peduncle. We also have an abnormality of the hippocampus. And if you go further cephalad, you'll actually see that there's abnormal signal in the choroid plexus. So in this host of infarcts, you have to now decide, where do you think the lesion is? Well, there's not a single lesion that will give you this pattern of infarction. This is a patient with posterior circulation ischemia with multiple infarcts, but all arising, in this case, either from a proximal basilar lesion, which is embolized, or a vertebral embolization. So again, this is not uncommon in posterior circulation infarcts to see multiple infarcts. Now, this specific finding is not well recognized. These infarcts of the choroid plexus are often mistaken for the normal variant anatomy you can have in the choroid plexus, these cysts that can be bright on diffusion imaging. But again, this is a real entity, infarction of the choroid plexus, because as you know, the posterior circulation gives off the posterior and choroidal arteries, which will supply the choroid plexus. This, however, is the part of I'm trying to show you the normal variant anatomy. Here, this is oftentimes the choroid plexus can be bright on diffusion weighted imaging. This one's confusing because it's unilateral, and that's of course because one side is calcified and one side is cystic. So again, this is normal, but what I showed in the other case, and you know they're different in the sense because of the clinical context, and that patient has multiple other infarcts. This is an example of some of the confusion that arises when people look at MR imaging. And I would ask, is this basilar occluded? So here's the basilar artery on the T1 weighted scan. Here's how it looks on the T2 weighted scan. Let's see. Hovhannes, what do you think about this? Could this basilar be occluded, or do you think this is open?
Hello, Dr. Mamourian. To be honest, I don't think this is fully occluded. So,
okay, so I think that is a reasonable statement. You can often have patients with atherosclerotic disease involving the basilar artery, and you'll note on the T2 weighted scan, you see the flow voids in the carotid arteries. But what I want you to acknowledge is the fact that the basilar looks a little different than the flow voids in the carotid arteries. So this is one of the difficulties with MR imaging, is, as I mentioned in a previous lecture, in the early phases of blood clots, they have short T2 relaxation time. So what you can see is this low signal intensity that resembles flow, but is in fact the T2 shortening arising from the fresh thrombus. So I think in a case like this, you might say, I'm not sure, but certainly you should acknowledge the fact that this could be occluded. And in this case, this was an occluded basilar artery.
I'm sorry, for this case, do we need a definitive examination like a CTA to just
Exactly.
confirm?
Exactly. And I think, but I want you to take away from that. I want you to be aware of this pitfall, because sometimes I've seen it, people will mistakenly say no, the basilar must be open because it's of low signal intensity on the T2 weighted scan. But remember, on MR, there are multiple sources of contrast. So the reason the vessel looks dark here is because this is called intravoxel dephasing, but basically we lose signal due to complex flow. Here we have the paranasal sinuses. These are low signal because there's no protons in there. And this is of low signal intensity, not because of flow. This is of low signal intensity because we have fresh thrombus in there.
I see. Thank you.
Yeah. Now, here's another pitfall you'll see in posterior circulation ischemia. People will see a scan like this and they see there's low attenuation on the CT scan. There's mass effect. It looks like a tumor in many respects, but this is in a sense a pseudotumor. And this swelling that occurs with posterior ischemia is different in terms of management, clinical management, because of the tight compartment of the posterior fossa with the tentorium forming the top and the foramen magnum at the bottom. And so this often requires surgical decompression. But when you see a case like this, I think your first assessment should not be that you're looking at a tumor. You should think to yourself, could this be a subacute infarct? Because they look very much alike on CT imaging. In that particular case, that was an infarct. And this is an individual with a cervical spine fracture dislocation, and the fracture involved the vertebral artery on one side. So what you saw was a cerebellar infarct as a result of that transected or compressed vertebral artery. Here's a 75-year-old woman with new dizziness. And what I want to show you is this was the scan that you're going to get in a patient like this. She's a little asymmetric. There's a little bit of artifact, you see here. This is the beam hardening artifact between the petrous ridges, and I think that this is shows you the difficulties with CT in posterior circulation ischemia. If you're very sensitive, sort of on the sensitivity scale, you want to call everything. You might say something about this, but we know that in this depression in the skull, we often get beam hardening artifacts. So if you call this an infarct, you would be overreading the scan. And then as we get down into the lower sections, you have these artifacts that go across the cerebellum. This, would you call that an infarct? Probably, you probably shouldn't. But this patient, I'll show you the MR scan. Having seen that, this is the MR scan in that patient. This is the inferior cerebellum. This is diffusion weighted, and here's the ADC map. This is an acute infarct of the cerebellum in this patient. This is what it looks like a little later on the FLAIR scan. So again, sort of as a magician, nothing up my sleeve. So let's go back and look at that area on the CT scan. This is actually an infarct here, impossible to call. So I think that if you call this in every patient, you're going to be have a number of false positives, and I think I can only tell you that from my experience, it's just very difficult to make the diagnosis on CT. And CT really, if you suspect posterior fossa ischemia, you could really just skip the CT scan, I think, and go to MR. This was a nice paper, went through the symptoms and signs of posterior circulation ischemia in a large registry of patients. And you can see the variety of presentations that patients can have with posterior circulation ischemia, the most common of which is dizziness. And so if you think about the ER physicians, how many patients they see with dizziness for all reasons, you can see why some of these patients are discharged without an appropriate workup. Now, let's think about some of the vascular territories where we're going to see the infarcts.
Let's do a question.
Yes.
In the clinical setting, it is quite common for the stroke doctors to be called a patient in the emergency room who is dizzy or has vertigo, usually older people. And the question to you is this: for these cases where there is clear change in the patient's symptoms, something new has happened, is an MRI, MRA necessary every time?
You know, I mean, again, let's,
if the MRI is negative, or admit him or her. What's your take about what's the best way to image the dizzy patient, acutely dizzy patient?
we can, you know, that's a very good point. I think it's analogous to the patient with headache. You know, if you think about how many patients come to the ER with headache, some of those patients have migraine, some of those patients have tension headaches, some of those patients have subarachnoid hemorrhage. And so I think the same sort of analysis has to go on. So in the dizzy patient, you know, the question would be, has there been, you know, is there a history of dizziness? How severe is the dizziness? How did it come on? But I think if there's a reasonable likelihood that you're dealing with a patient, let's say you have, and I've seen this a number of times, an elderly patient has acute severe dizziness in the sense they're unable to stand because of it. And you don't think it's benign positional vertigo, then I think those patients benefit most from an MR scan with an MRA. And I think you can skip the CT scan, as I say, because of the false positive and false negatives. That's my, that would be my suggestion. But I think that it's again this is clinical medicine in the real world. You're going to have a number of, if you have a number of patients with false, you know, again, you do the MR scan and there's no finding, that doesn't mean your judgment is flawed. It just means that you may be, you know, sort of too sensitive. If you only order it now and then and they're all positive, you're probably missing some patients who have posterior circulation ischemia. So again, I think it's a good question, but a difficult one to answer because it really is in the end based on the clinical judgment of the physician in the ER.
I have a question, Alex.
Yes.
As I work in a hospital which doesn't have a stroke program, we have a couple of cases where a patient just walks into the MRI clinic and we find this kind of stroke in his images. And in some cases, they just go to the neurologist who tells them to what kind of treatment to get, and they go home if it's not a big area. What do you think? Which is the best time for the follow-up? How many weeks after shall we call them to the MR to see the difference in the lesion? What's your opinion?
Well, let's break it down into two sort of categories. We'll talk about young and old. So and you can I don't know exact cutoff of that. Certainly, if I have a 30-year-old patient who has a posterior circulation, you know, cerebellar infarct, I'm going to assume they have a vertebral dissection till proven otherwise. And there is a specific management for vertebral dissection at many hospitals, and sort of varies, I know, but they're usually not just sent out with a vertebral dissection. So again, if I see a young patient with a new cerebellar infarct, I think they need to have vascular imaging to determine if they have a vertebral dissection. In an older patient who's particularly if they have vascular risk factors, I'm going to assume that they have some atherosclerotic disease involving the vertebral artery or pica. Again, that's the important thing in those cases is how large is the infarct, because with as I indicated, with a large territory cerebellar infarct, like most of the pica territory, those patients can go on to have swelling to the degree they'll herniate and could perish. So I think for those individuals, they need to be probably hospitalized and observed to decide if they need neurosurgical decompression. But for an elderly patient with a small cerebellar infarct, then I think that is reasonable to follow them, conservatively. But again, I leave it up to the neurologist, how they want to manage it at that point, whether they should be on aspirin or something of that sort. Does
Okay,
that answer your question?
yes, of course. Thank you.
So let's talk a little bit about the territories, so you can sort of, when you see infarcts in these territories, gives you an indication of where the lesion is. So there's this concept of the top of the basilar artery infarction. This can involve choroidal arteries, as I mentioned, with choroid plexus infarcts and thalamic perforators that I showed you at the beginning. These are on the proximal posterior cerebral arteries. So you can, in these cases, what you'll see is it can be infarcts of the choroid plexus and infarcts of the one or both thalami. The superior cerebellar artery territory is the sort of the upper side of the cerebellum. So again, if you would put your, like as if you have your hands on top, on the bottom of holding an apple in your hands, not from side to side, top and bottom. That's how you think about the superior cerebellar artery, is the upper hand, sort of goes over the top of the cerebellar hemispheres and stops somewhere around the horizontal fissure. Pontine perforators, I mentioned, these are unilateral infarcts that spare the midline or stop at the midline. Anterior inferior cerebellar artery territory, we don't see these infarcts very often, but these are usually going to be in the anterior portion of the middle cerebellar peduncle. Posterior inferior cerebellar artery is the sort of the other hand, sort of covering the undersurface of the cerebellum. And then vertebral artery, of course, can involve multiple territories. These can involve the medulla, from perforators to the medulla from the distal V4 segment of the vertebral artery, and pica as well. And then I want you to keep in mind there is also a watershed in the posterior circulation. This is not talked about at great length, but this watershed runs around the horizontal fissure and often involves the subcortical white matter that you see here. I've only seen, I saw one case that actually went to autopsy. It was a patient years ago who had chronic hypertension and was over medicated in the emergency room to reduce blood pressure. They became hypotensive in the ER, and they ended up with watershed infarcts, both in the cerebral hemisphere and in the cerebellum. So don't forget that there's a watershed. In this case, as I indicated, the superior cerebellar covers this portion of the cerebellum. Pica covers this portion of the cerebellum. This then, along the horizontal fissure, is the watershed territory. Now, this is from that registry. They divided the symptoms up into the upper, middle, and lower. And again, we'll talk a little bit about these infarcts, but again, the middle is this is the typical appearance of the basilar occlusion that we'll see on occasion. The upper portion of the posterior circulation, we're going to be dealing again here with the top of the basilar. These are the branches that supply the thalami and the choroid plexus. And then these of course are the superior cerebellar arteries. And then the lower segment, this is going to be pica and vertebral artery as shown. So let's look at a left posterior cerebral territory infarct. So again, the posterior cerebral artery has no branches into the cerebellum. And here we see, again, the involvement of the medial temporal lobe, sparing of the lateral portion of the temporal lobe, sparing of the temporal tip. Usually the posterior cerebral territory extends up to about the tip of the temporal horn of the lateral ventricle, and will involve the hippocampus. So again, this is a typical posterior cerebral artery infarct. This one subacute in the sense we see the swelling, with effacement of the cortical sulci, a little bit of mass effect on the cistern, and so on. And again, the involvement of the posterior cerebral artery extends into the medial portion of the occipital lobe. And this, of course, the symptom you would expect. Well, let me see, who wants to tell me what is the, what symptom would you expect to see with this patient? One of the complaints they may have.
Visual problem.
Vision, exactly, right? So we
Yes,
expect
sorry.
that
Oh, yeah.
homonymous hemianopsia
Hemianopsia. Yeah.
on the contralateral side because of the optic radiations. Very good. So again, often the occipital infarcts, because of the involvement of the calcarine cortex and the visual cortex, will have a homonymous hemianopsia, and that may be how they present. But again, it's a nice depiction of the posterior cerebral territory as compared with the middle cerebral territory and the watershed, the interface between the two territories. This is an example on digital subtraction angiography of a posterior cerebral occlusion. This is the superior cerebellar artery on this side, and here you see the posterior cerebral on the other side. And here, this is superior cerebellar, and this is probably thrombus sitting in the orifice of the posterior cerebral artery. This is the same patient. This is at the time of the arrival in the emergency room, and this is after thrombectomy. Here, just to pay attention to the difference in appearance, superior cerebellar artery, this little divot here at the thrombus at the top of the basilar artery. This is after thrombectomy. And so here you see the normal appearance of the posterior cerebral arteries and the normal V that appears at the top. And again, this is where the perforator branches are going to come off. Also notice how this is probably an older patient, you develop this dolichoectasia, which is a little bit of enlargement and a little tortuosity of the basilar artery, which creates so much trouble for us on CT imaging because of the asymmetry that will occur from this sort of tilt that occurs at the top of the basilar. Now, this is an imaging is confusing, I think, for a lot of individuals, and I want to bring it to your attention. Here we have a patient with bilateral thalamic lesions. This is T2 weighted. Here's FLAIR. Here's another one on diffusion imaging. So when you see these bilateral thalamic infarcts, you have to ask yourself, could this be infarction? Could this be metabolic? Because there is an overlap in the appearance. And quite honestly, I think in many cases, it's difficult to distinguish based on just the MR imaging alone. You have to look at the clinical context. So this is a reasonable differential diagnosis you should consider for the patient with bilateral thalamic lesions. As I mentioned, there is a top of the basilar infarction. Now, you'll hear this term occasionally, the artery of Percheron. This is an artery that arises at that V at the top of the basilar artery, but it's a single vessel that supplies both thalami. So what you could see is involvement of thalamic perforators bilaterally, or it could be involvement of a single artery with bilateral representations in the thalamus. Occasionally, patients with PRES, which is usually associated with medication and hypertension, can be manifested in both thalami. Don't forget the venous system. Bilateral internal cerebral vein occlusion or straight sinus occlusion can manifest as venous hypertension in both thalami. And I can tell you over the course of my career, more than once have we been wrong in patients with bilateral thalamic disease that it turns out to be either cerebral vein occlusion, or this is less common but important to be aware of, a dural fistula involving the straight sinus can cause venous hypertension in both thalami. Now, this is very difficult to diagnose because when you do the MRA or CT venogram, you'll see that there's flow in the internal cerebral veins, and you'll conclude incorrectly that it's not due to venous disease. So be aware of this possibility. Wernicke's encephalopathy can manifest in bilateral thalami. Osmotic demyelination, or used to be called central pontine myelinolysis, CPM, can manifest in the thalami, and occasionally just Creutzfeldt-Jakob disease, although usually not in the same distribution. This is a patient, of course, with CJD, and this is the appearance you'll see on diffusion imaging, oftentimes with basal ganglia involvement here in the lentiform nucleus, and this sort of hockey puck or hockey stick appearance in bilateral thalami. This is a patient who had a thalamic hemorrhage from a straight sinus and internal cerebral vein occlusion. Let's see. This was actually a paper we published years ago. And you can see in this illustration, there was bilateral thalamic abnormalities on the T2-weighted scan. These patients present clinically, have kind of an unusual presentation, often apathetic. So in terms of not a focal neurologic deficits. And in this patient, you can see the internal cerebral veins were open, but on angiography, there was, you can see this is during the arterial phase, we have this venous filling. This was from a dural fistula. This is what the patient looked like after surgery and occlusion of the fistula with resolution of the venous hypertension. So again, be thoughtful in patients with bilateral thalamic disease of the possibility of a venous cause. This is
Yeah.
Yeah.
I'm sorry. Can I ask a question, or we leave it
Yes, of course. Yes.
Okay, thank you. If we suspect the cerebral vein occlusion, the first imaging choice is CT angiography or any other?
I think MR or CT, MR venogram or CT venogram, either one.
Can I ask you very much, if it's possible, just can we have any lecture about the venograms?
Well, if you look on the schedule, that's coming up. I think that's in the next.
Okay. Thank you so much.
Yeah,
Okay.
I'm going to go through, and actually I'm going to go through mostly MR venogram because there's so many artifacts on MR venograms. And I would say, depending on your experience and your imaging site, I think there is a tendency to gravitate towards CT venogram because it's just easier to read and there are fewer artifacts. So if you're not experienced with MR venography, then I think just go to CT venography.
Thank you.
You're welcome, Anna. I just want to show you this case, this patient. You can see there's this infarct. This is a diffusion weighted scan, and you can see there's abnormal signal here in the corpus callosum, which is unusual. There's involvement here of the caudate and the thalamus, kind of an odd constellation. It looks very tumor-like, but this is the angiogram, or I'm sorry, venous injection. Here the catheter is in the internal jugular vein, just inferior to the jugular bulb. Retrograde filling here of the sigmoid sinus into the transverse sinus, and you can see there's it's refluxing down the other side without any filling of the straight sinus or the superior sagittal sinus. So that imaging, which looks not only does not look like an arterial infarct, it looks actually very much like a tumor, was all due to venous infarction from this deep venous occlusion. So again, keep venous disease in mind, particularly when you see abnormalities involving the thalami, or you see like a non-vascular territory ischemia. Let's look at this case. Here's a CT scan. And what I want you to notice here is, I'm sorry, let's go back. Sort of gave it away there. So we're looking here, I'm telling you that the patient has unilateral symptoms. What you'll notice here is there's low attenuation in the pons. This is visible only on one slice, and you have the beam hardening artifact that of course goes through the petrous bone. And you could argue that this is more evident on this side because of the head tilt. So this is what I mean about the difficulty of making the diagnosis of CT on CT. We have a combination of a lesion that's in the same place where we often see an artifact. Let me ask Mariana, which side with the patient have symptoms on with a lesion in that location? I'm sorry, Marina, are you with us?
Yes, 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 I'm here.
So which side do you think the symptoms are on?
Which side?
Yes.
Oh, maybe the same side.
Okay, so so again, you have to think about where the lesion resides as it relates to the crossing of the motor fibers. So if we know that if you have a, let's say, if I told you that the infarct was in the motor strip, sorry, was on the motor strip in the right hemisphere, which side would the symptoms be on?
On the left.
On the left, right? Because we know that the motor fibers cross.
Mhm.
So in this case, as we see there's a lesion in the pons, we have to ask the question, at what level do the fibers cross to the other side? Because if they're going to get from the right side to the left side of the spinal cord, right, they have to cross somewhere. So do you know at what level do the fibers cross?
I don't remember exactly.
It's in the upper medulla, somewhere in the medulla. So it can be in the upper, like I think oftentimes it's in the mid to lower as well. I think, and they may not all cross at the same level, but you can be pretty sure that at the level of the pons, right? In this image, we can tell we're not, this is the medulla down here. This is probably medulla there. This is at the transition, but this is definitely in the pons. So in the pons, we're above the decussation. So a lesion in the right side of the pons will still give symptoms on the other side. Whereas a lesion in the medulla, it'll be in the lower medulla will be ipsilateral. Does that make sense?
Yes.
So a lesion on this side, on the right side, in the lower medulla will give symptoms on the right side, but a lesion in the right side of the pons gives symptoms on the opposite side. I just want to review that. So again, looking at, that's what the CT looks like, and we've seen it a few times. This is what the MR scan looks like to match that. So this is the diffusion weighted scan. The conspicuity on MR is much, much greater than on the CT. And I'll show this to you side by side. Here's the, this is actually another patient, but it's just showing you what a pontine infarct looks like on the CT, and this is what it looks like on the MR scan. So this is why I think MR is much better and pretty much across the board for all patients with suspected posterior circulation ischemia. You'll also notice that the pontine perforated infarcts always spare the midline, right? They don't cross the midline, which is why helps you discriminate them from some of the other problems. Now this one breaks the rule. Here's a patient with a lesion in the midbrain. Here we're in the midbrain. Here we're in bilateral in the pons. So if you take me at my word, you would say, well, this patient, these are probably not ischemic, but this is what the MRA looks like in this patient. This patient actually has a lot of disease in the V4 segments in the proximal basilar artery. So these are probably a combination of acute and chronic ischemia. But again, you can occasionally see cases like this. So it's not 100%, but it's pretty reliable that most pontine infarcts are unilateral. This one I want to show you, this is a patient with, I'm sorry, this patient, if you look carefully, you'll see this low attenuation here in the pons. And again, I would attribute this all to beam hardening on the CT scan. But this was done just shortly afterwards. Here's the MR scan. Now you notice this lesion that's squarely in the center of the midbrain and pons. So when you see a lesion like that, you should be very skeptical that this is ischemic. And this patient had a history of rapid correction, was an alcoholic with rapid correction of sodium. So this is most consistent then with central pontine myelolysis, which, as I say, is often now called osmotic demyelination. But I want you to appreciate the difference between this lesion, the lesion I showed you in the previous case, that kind of blotchy lesion that was ischemic, and the unilateral pontine perforator that I think is the most typical appearance.
Oh, sorry, can I have a question?
Yes, yes.
Hello to everyone. I just wanted to know how often during osmotic myelinization this lesion in the pons can be associated with other lesion in the basal ganglia. Can it be because if I can't mention, we had one patient, young woman, and she had a lesion in pons and also some small lesion in basal ganglia. And at the last diagnosis was osmotic myelinosis. How often you see these cases and how you can help in this situation?
In my professional career, I have never seen a case of osmotic demyelination involving more than the pons. So those cases, the only time I usually see those cases is on, board exams or, national conferences. I think it's really quite rare. But having said that, I mean, there's certainly a literature that tells us that you can see involvement outside of the pons in that situation of rapid correction of sodium. So I think it's certainly possible. And I find that in these cases, the clinical history is the most helpful feature, that if you have that clinical context, and there shouldn't be much question about it. And you see involvement of the pons and basal ganglia, yes, I think you're probably dealing with osmotic demyelination. And that's why the terminology, I believe, changed from central pontine myelolysis to osmotic demyelination, to sort of help explain why we see extra pontine involvement. So again, I think it's really quite uncommon, but it's certainly a possibility.
Thank you very much. Thank you.
Alex, I have one question. If we are seeing osmotic demyelinization, do you think that it would be correlated with the ER experience with you using a hypernatremia or something? You need to give electrolytes in a very high level, in a very high speed, right? It cannot be without the correction of the sodium.
No, I thought it was usually the rapid correction of sodium.
It cannot be a disease called. It needs to be some intervention with the sodium to have that image.
That's my understanding. Yes. Yes. Mm-hmm. Okay, now let's look at this scan. This is a 40-year-old patient. His wife, he was feeling nauseated in the morning and a little dizzy, and he decided not to go to work. His wife went to work, came back at lunchtime, and found him unconscious in bed. So this is the CT scan. Mariana, do you want to look at, or do you want to tell me what you see on this scan?
I see a thrombus in arteria basilaris.
Excellent, excellent, exactly. Now this, in my opinion, is a difficult diagnosis, and I think you nailed it. So unlike the middle cerebral arteries where we can compare one side with the other, the basilar occlusion is much more difficult, but the concept is the same. If you look at the attenuation of the posterior cerebral artery, here you see, and this is what you should look for if you want to exclude the possibility of a basilar tip aneurysm in a different circumstance. When you see this little divot in between, this is that, if you think about that V that forms at the apex of the basilar artery, it's going to give you this little divot in the center as the posterior cerebral arteries sweep up. But if we go down from there, you see the way the attenuation changes, and as you quite accurately noted. So this is a thrombus in the basilar artery. Now, this can be misleading in some older patients where you can have calcifications that can, because of volume averaging, can masquerade in this way. But when you see it, and again, in a clinical circumstance like this, then I think you're most likely dealing with a basilar occlusion. And again, notice the way that attenuation changes as you go cephalad. Again, you see that change. And so the idea is that as the clot retracts, the attenuation goes up. And so it has a higher attenuation than intravascular flowing blood that you see elsewhere. Excellent, very good. So this is the dreaded basilar occlusion. Now these patients, there's some controversy about what to do next, depending on in this case, the time of the occlusion was known. And so the patient went directly to angiography. This is the angiogram, which shows you the flow in the injected vertebral artery. Here we have the V3 segment, V4 segment, confluence with the other side. There's this truncation of the basilar, and we're actually refluxing down the opposite vertebral artery, in this case with an occluded basilar artery. And this was treated with let's see if I have that. I don't think I have the but this was treated with thrombectomy. But not all patients, here we are, post-lysis or thrombectomy. And here we see the normal appearance of the vertebral artery. Here's a little bit of reflux on the other side, but not as much reflux because now we have flow going distal. This is again that V, but you'll notice that the superior cerebellar artery is occluded. And so this is what happens oftentimes is you have distal emboli. You see the same thing in the intercirculation. And so these patients, I like to say they all do well, but that's not true. And I'll just bring your attention to this. Let's see. This was from 2021, New England Journal of Medicine. And this was a study looking specifically at this basilar artery occlusion situation. And they concluded that endovascular therapy and medical therapy were not significantly different with respect to a favorable functional outcome. But we could not exclude a benefit of endovascular. So unfortunately, after all of these years, we've been sort of dealing with basilar occlusions and that coexisted in this era of intervention. it's still not entirely clear that the intervention is helpful in cases that they weren't able to demonstrate it. But the reality is that if you have a patient who's a candidate for endovascular treatment, it is difficult to sit on your hands and not do anything in these cases. Lower segment involvement, as I mentioned, vertebral occlusion or dissection, pike occlusion, medullary. These are what we deal with in this lower segment. Here's a patient with bilateral vertebral dissection. I just want to show you what it looks like on the CTA. So as we go down, we see the V4 segments here of the vertebral arteries. And then this is the V3 segment. Do you see how narrow this is? And it looks like there's a casing around the vertebral artery, right? This is a vertebral dissection, and you see the same thing on the other side. It looks like there's like a halo around the patent lumen. So again, this is a patient with bilateral vertebral dissections. This is what you should be looking for in all of your CTAs. So you become familiar with the appearance of the V3 segment. Now, in this case, on the left side, this is what you expect to see. There should be fat that comes all the way up to the posterior border of the V3 segment of the vertebral artery. But on the right side, you'll see this halo around the lumen of the vertebral artery. See that the fat doesn't come to the border of the vertebral artery. This is a vertebral dissection on the right side. And I want to bring your attention to this paper.
I'm so sorry. Can we name it chronic dissection, or we don't use this terminology?
No, I wouldn't. I mean, that's certainly those cases.
I mean, it's not after trauma, and we know if it's not severe. Can we call it chronic dissection, or we name it only dissection and it's enough? That's the question. Thank you.
Yeah. Yes, I would. I mean, I would, unless I had a previous scan, I would just call it a dissection. And I think most of those cases are that I've seen are acute. And I want to bring your attention to this, and this is different, a little different than in carotid dissections, because usually in carotid dissections, in virtually all cases that I've seen of carotid dissections, the lumen is narrowed. But there is this entity of sparing of the lumen, but this wall hematoma that you see here in this article is just what I showed you in those two cases. You have to become attuned to recognize this appearance on CTA. So look at the V3 segment and all of your CTA scans so you become familiar with this appearance. This patient, as a result of this dissection, had a lateral medullary infarct. So again, it's not a concept that is known widely, and I want you, as my Armenian experts, to be aware of this. Now, here's a patient, coming to your point about chronic dissection. This is a patient with that appearance on the right side. Here's a normal. See the way the fat comes to the posterior border of the vertebral artery, but there's this extra tissue around the vertebral artery on the right side. The lumen is preserved. This is what the patient looked like 3 months later. So most often in patients with vertebral dissection, particularly in the trauma patients, the vertebral artery, and in young patients, usually the lumen recovers. So the vessel goes back to a more normal appearance over time. Now, I will tell you there's one pitfall that you will see. Sometimes there can be veins. If you have a patient who has a hypoplastic vertebral artery, so meaning that the vertebral artery is the same caliber all the way down to its origin, sometimes you'll see unopacified veins that sit behind the vertebral artery. That is probably the most common pitfall I've seen where this gets overcalled or a false positive. But again, if you have a patient who has this and an acute infarct, then I think you can be pretty sure that you were dealing with an acute dissection rather than an artifact. Here's a patient with acute paresis and sensory changes. This is a lateral medullary infarct. You can see here. And let's look at the, can we tell about the vertebral arteries? Here you see the patent lumen of the vertebral on one side and not on the other. Again, in this patient, if we go to the MRA, here's the MRA, and you can see there's flow-related enhancement in the right, and there's actually signal loss on the left, again, due to thrombus in the blood vessel. So again, MRA very helpful in these cases where we're trying to establish vertebral occlusion. This is actually a picture in Armenia in one of your beautiful churches. So I'm going to change gears here and talk a little bit about the imaging of arteriovenous malformations. It is more likely that you're going to find.
I'm very sorry.
I'm sorry.
I'm very sorry. Can I give one technical question? I'm very, very sorry to disturb you. Yes,
No, no,
yes.
not at all. No,
I
that's the
just
whole
want to
intent
know,
here. I
I'm
like questions. Yes.
I'm very sorry. When you want to see posterior circulation ischemia, do we need to do on MR for diffusion thin slices, 3 millimeters, or it can be standard 4 millimeter slices MRI for diffusion?
Oh, I think 4 millimeters is fine.
So no need to do thin slices. Thank you.
So, no, I don't think for diffusion that you need thin sections in the posterior circulation.
Okay, thank you very much. Sorry again.
Oh yeah, no. But I mean, I think you'll have better signal, and I think you'll actually, the image quality will be better too.
Okay, thank you.
Alex,
So
a question or two from me, if you have a moment.
Yes.
Yes, we can. First, any comments about the anterior spinal artery? Second, thalamic infarcts are quite common. Can you tell us a little bit more about, besides the artery of Percheron, what other arteries from the basilar, PCA, pica, and so forth go to the thalamus? What's the vascular supply of the thalamus?
Well, there are. I wouldn't say I'm an expert on this, but in my understanding, the majority of the thalamus is supplied by thalamoperforators that come off of the proximal P1 segment. There is supply to the lateral thalamus that comes from the anterior choroidal artery, but those cases also have involvement, usually with occlusion of involvement of the posterior limb internal capsule. So pure supply from the anterior circulation, particularly involving much of the transverse dimension of the thalamus, would be unusual. That's really the way I think about it. I don't know, is there some, or is there something you have in mind when you ask that question?
No, but that says it. The anterior choroidal goes in that area, and of course, it's an internal carotid artery branch. And then the PCA, pica penetrators, in addition to the artery of Percheron. It's quite a complex structure, actually.
Yes.
How about the anterior spinal artery, which you mentioned when you started? Any comments about that?
Well, I think in terms of involvement of the anterior spinal artery, I think I have not seen a case of spinal cord ischemia associated with vertebral occlusion or dissection, presumably because you have bilateral contributions to the anterior spinal artery and you have other supplies. So I think a vertebral, I wouldn't say it's impossible, but I think it's uncommon.
Okay, thank you.
So just in this last segment of the talk, I want to talk, I don't think we're going to have time to get into vasculitis, so I just want to cover arteriovenous malformation imaging because it is uncommon to find unruptured arteriovenous malformations. But I do think you need to be aware of them because you want to recognize them prior to hemorrhage. So how can we identify an arteriovenous malformation unruptured? You want to look for enlarged feeding or draining vasculature, that is enlarged veins or arteries. This is an important finding: focal high attenuation, serpiginous high attenuation, and calcifications. If you see any one of these, or particularly all three of these, you have to think about arteriovenous malformation. The reason I want to talk about this is that I've seen a few cases now where arteriovenous malformations were mistaken for subarachnoid hemorrhage. And so it is an important distinction. I've also seen cases where the calcifications are overlooked. So let's take a look at some of these cases now. This is a typical appearance of a ruptured arteriovenous malformation. That is a lobar hemorrhage, oftentimes in a young patient. As I say, this one was not recognized on the first DSA. So in the acute phase of the blood, if you do a digital subtraction angiogram, you may not see the arterial shunt. So this one was, the AVM was actually found on the second DSA. So in this case, there was a normal CTA, a normal DSA, and then the abnormality was found on the second DSA. But what I want to show you are cases of unruptured arteriovenous malformations. So as we look at this CT scan, this patient I remember quite well. This was I don't think I have the history. I thought I had the history on here, but this patient was found. This was the last case I saw on a weekend when I was on call, and I spent some time looking at it, having looked at I don't know how many cases that day, 100 cases. But there was something about the case that got my attention. It was the history. Was the patient was found wandering around their house late at night and seemed very confused when his wife found him and brought him to the emergency room. But he sort of cleared up. His thinking cleared up when he got to the ER. And so there was an inclination to just discharge him and sort of chalk it up to some mysterious, night sleepwalking. But the important finding here is this little bit of high attenuation. Do you see this right here and here? So when you see these calcifications, unexplained calcifications, or you see the vasculature is also going to be a little denser than the brain. In a case like this, who may have had a temporal lobe seizure, you really have to pursue it. So that is an example of a early, sort of the very subtle findings of an arteriovenous malformation. Now, I'm going to show you the MR scan in the same patient. This is what the MR scan looked like. Now, again, you look at the MR scan and you say, well, I mean, that's so obvious. But let's go back to the CT scan. Now you know where to look, right? This is the arteriovenous malformation. So it's these little calcifications that give it away. So again, if you have, in this case, where you have a reasonable history, in this case probably was a new seizure with this kind of unusual behavior, and you should go on to an MR scan. Don't have to do a digital subtraction in every case here, but I think this shows you the increased sensitivity of good quality MR scan in a circumstance like this. So this is a different concept, but you want to be thinking in AVM cases about the venous drainage, because that's important to the surgeons in terms of vascular risk. Let's look at this as another CT scan in a patient with new seizures. And what I want to show you is the finding in this case is right here. So again, very easy to mistake this for subarachnoid blood, but that was an arteriovenous malformation. Here's another case I want to show you. This is what this finding actually appeared on an MR scan, and the patient got post-GAD imaging, post-gadolinium, and you see it looks about the same on post-gadolinium. So again, if you're tempted to call this a DVA, but it doesn't enhance after gadolinium, you're probably dealing with a high flow vascular structure. DVAs all enhance after administration of contrast. So again, if there is no enhancement, you have to be thoughtful that you're dealing with high velocity flow. This is another arteriovenous malformation. Here's a patient. This was the finding in this patient. This is a temporal AVM. There's a calcification. There's some high attenuation. Again, I can see why this might be mistaken for hemorrhage, but this is an arteriovenous malformation. Here's the nidus. Here's the draining vein. This one, I'm going to skip that one. Now, this last case I want to show you, this is another finding. This is a patient with pulsatile tinnitus. And while nothing, sort of obvious here on the MRA, what you should be looking for is this: large penetrating arteries that are asymmetric. So you see this little bit of signal here and this large penetrating vessel here. This should be enough in a patient with pulsatile tinnitus for you to recommend digital subtraction angiography. And here's the DSA in that patient. And let's see. Edward, do you want to tell me what vessel this is right here?
What part? Sorry.
I'm sorry, say again.
About what vessel do you ask me?
Oh, I'm still having trouble hearing. But this is what I wanted. I'm showing. So this is the internal carotid artery, but there's this large vessel here that sort of comes across here, and you see this early appearance of a vein. So what artery is this right here? Is this I guess the question is this an intra dural or an extradural artery?
I think extra.
Exactly, yeah. So this is the ICA, and there was a little reflux that probably went into the external, and it goes out this giant occipital branch. So this is a branch of the external carotid artery, which is enlarged. So we have a large feeding vein, and we have the early appearance of a vein here. And so that what I showed you on the MR scan was the penetrating artery from the occipital artery to the dural sinus here, the transverse sinus. And so this is a typical appearance of a dural fistula. Dural fistulas often have, as one of the presenting symptoms, is pulsatile tinnitus. So again, arteriovenous malformations are supplied by the Peel branches. These are the intradural, sort of the posterior circulation. The dural fistulas are supplied by the external branches, in this case, occipital branch. I guess we have a little, I want to maybe just show a couple cases. Maybe you can help me with some of these cases. Now, do you want to help me with this case? This is going to be a 35-year-old with a history of clumsiness in her left arm. She'd been seen in an ER early in the day, had a normal CT scan, but she went home still complaining of this difficulty with her arm. Her brother was actually an ER physician and insisted something must be wrong. She went to another ER. She has a history of childhood leukemia for which she received brain radiation. So she ended up having a CTA, an MR scan with an MR perfusion. And so this is her cerebral blood flow scan, cerebral blood volume scan, and her mean transit time. What does this tell you? I'm sorry, Narek, are you still with us? It may be bad connection. Telman, what do you think about this? No, Anna, do you want to, Anna, are you with us?
Yes, it's me.
Yes. What do you think about these scans in this patient with this kind of odd, it's not paralysis, it's like a clumsiness of her arm?
Actually, really, I'm not the MRI specialist, but some discrepancy in the parasagittal frontal areas.
Good. Yes. Yes.
Yep.
Good. So, and which side do you think is normal?
Sorry?
Which side is abnormal, do you think?
The right side is abnormal.
Good. Okay, so let's look at this. So we see the cerebral, usually if you look at the scale, right? So the idea is that this is more, this is 0. So
Yep.
the red, yellow and red is going to be higher cerebral blood flow. We expect the cortex to have higher cerebral blood flow. But on this side, there's actually less flow, not just here, but throughout the hemisphere. Now, you notice that the cerebral blood volume image is actually pretty symmetric, right?
Yes, pretty symmetric. Agree. Yes.
And this is mean transit time. So what can we do you think this is all infarcted?
Oh.
Because we talked about that, in terms of how to use cerebral blood flow maps or perfusion imaging to predict the penumbra and the core infarct. So my question is this all infarcted, do you think?
Is it?
Well, so this is how I would approach this case, is that if the cerebral blood volume image looks normal, right? So one of the predictors of infarction is impaired low cerebral blood flow and low cerebral blood volume. But we do not have low cerebral blood volume. We have normal cerebral blood volume. But if you look at the mean transit time, this is low this is low, this is high. This means this is 10 seconds. Let's say this is 10 seconds. So the blood is getting to this cortex later than on the other side. But the cerebral blood volume is the same or even greater on this side. So this is a typical appearance of collateral flow.
Okay.
So with collateral flow, you're going to have late arrival, but you have normal cerebral blood volume.
Okay.
But diminished cerebral blood flow, because it's not, again, the pipes are, instead of going through these large arteries, it's going through a lot of smaller arteries, maybe leptomeningeal collaterals, that sort of thing. So this is a typical appearance of collateral flow. Now, this patient actually
I'm sorry, can I have a question?
Yeah, yes.
So the right side is penumbra, that blue one we see.
Exactly. I think that's it. That's a good way to think about it. This is the way a penumbra would look.
Okay, thank you very much.
Now, this patient did have a small infarct. Now, does anyone tell me how you can explain those symptoms, or what part of the brain is involved here?
Oh.
We haven't talked about this. I don't know if anyone recognizes this syndrome.
Oh, no.
This is supplementary motor area. Supplementary motor area is medial frontal. And so this complex of symptoms, this clumsiness, is a little unusual. And sometimes you'll see these supplementary motor infarcts in your practice, and oftentimes the patients will recover from those infarcts. But what we know is that the involvement is not just here. We know that there's some abnormality of the whole hemisphere on this side. So if we go to the imaging, you'll notice there's a diffuse disease, right? Neither side looks normal. This doesn't look normal. And so I wanted to show you this case. This is a patient with accommodated, like a distal carotid stenosis. with impaired flow throughout that whole vascular territory, but with collateral flow making up for the impaired inflow. And this is a patient with radiation vasculitis. Probably from their childhood leukemia and the radiation, they went on to late arteritis. I'm going to show you another case, different case. Here's a 24-year-old with sudden severe headache 3 days after delivery of her first child. This is her MR scan. They thought maybe that she had a venous occlusion, which can be seen in the postpartum period. Her MR scan was surprising, as it looks like she has infarcts. Anybody want to tell me what territory this is?
Posterior cerebral artery.
No, because we're up here in the white matter. See that?
No, it's watershed.
It's a watershed.
Watershed. This is typical watershed ischemia, but there's another unusual finding is the corpus callosum is involved. So it's a very unusual vascular pattern of involvement. You almost never see callosal infarcts in normal circumstances.
It's a venous occlusion, yes.
That would be an excellent thought. That would be an excellent thought. But she ended up having an MRA. This is what her MRA looks like. So again, she's 3 days postpartum. She has an abnormal MR scan with all of these venous vascular stenoses involving both sides. Look at the tapering of the distal ICA on both sides, tapering of the MCA, narrow A1. So she has a diffuse, this is what I want to show. This is a diffuse vascular abnormality.
Syndrome.
I'm sorry, what syndrome? What should you consider in this circumstance?
Puff syndrome, like I forgot the name of the syndrome. Puffy artery.
So what we thought, we considered vasculitis in this case. And so she had a spinal tap, which was negative. And she had no symptoms from those infarcts. So she was discharged, and we thought this could be reversible cerebral vasoconstriction syndrome, which can occur in the postpartum period. It's usually not associated with infarcts, but it was, we think it was in her case. This is what she looked like 2 months later. So this is what she looked like in that acute phase. She had a complete she went back to normal. This is what you can expect in this disease of RCVS, is this return to normal and a normal spinal tap. So I'm showing you these cases. The first case I showed you is a radiation vasculitis. This case is this kind of a mysterious disease, but some sort of probably autonomic disease, involves diffuse vasoconstriction, which is reversible. And then I'm going to show you one last case. This is a 19-year-old with new left-sided weakness and sensory changes. This is her CT scan. You can see there's some low attenuation here. See that area of low attenuation? So again, in terms of early findings of infarct, cortical involvement, subcortical involvement, she went on and had an MR scan. The MR scan looks like this. Here's the diffusion weighted study. And this is the ADC map. Hovhannes, are you still with us?
Yes, hi.
So looking at this, so if we look at this diffusion scan and we look at the ADC map, can you predict whether this is infarct occurred at one time, or could this have occurred at different, could there, in a sense, could there be an acute infarct superimposed on a chronic infarct?
Yeah, of course. Because the lesion is not homogeneous, so there are certain parts that have this high restricted diffusion and the other parts don't. So probably.
Excellent. Exactly right. That's exactly right. And so that's why I want you to make a practice, all of you, make a practice of looking at the diffusion scan and the ADC map together. because in this case, you might assume this is a single infarct, and there actually looks like a little bit of watershed ischemia here. You see this? All of these little areas of high signal. The problem with the diffusion weighted trace imaging is it's both T2 weighted and diffusion weighted. The ADC map is less T2 weighted. So this area actually has facilitated diffusion. This area has restricted diffusion. So there's an acute infarct superimposed on a chronic infarct. Whenever you see that, you can be pretty sure that there is a vascular structural abnormality underlying this. So this is not the appearance you would see with emboli, different times. And this is her angiogram. And so here you can see she has this tight stenosis of her proximal M1 segment and a stenosis of her A1 segment. And this was called Moyamoya disease. This could be one of the manifestations of Moyamoya disease, but this was probably related to, I'm sorry, in this case, this is idiopathic. There was no real explanation for why this occurred, but I want you to recognize that whenever you see that appearance of infarcts in the same territory of different ages, think that there is an underlying vascular stenosis. I think we're going to end with that. And I really appreciate you staying with me and your input and questions. I'll be posting this online again, so feel free to review it in that fashion. But that's all I have today. Any other questions for me?
Only thank you.
You're welcome. Very welcome.
Alex,
Thank you very much.
I think it will be good if we will have a good table of all stroke syndromes in one place with the clinical representation. So I sent a few tables which I have from my USMLE exams, which is it's easy to remember. But
okay.
if anybody have a good tables with clinical representation of the different syndromes, it will be good that all the doctors will have it in front of them doing the imaging.
Okay, I'm not okay. If anyone has it, that would be great. That would be very helpful.
I sent it a few, but somebody might have a more comprehensive table for the syndromes.
Okay, perfect. Thank you all. Thank you all. And again, if you just looking ahead, I've decided to truncate the course a little bit at the end. It was originally going to be 12 weeks. We're going to do 10 weeks. So this is week 7. So there are going to be 3 more sessions. I have a venous disease lecture coming up for you. You can look ahead at the schedule, but I think we're going to, the last week, the 10th week, there's going to be a final exam. And so I want, if you think there's some area that you're not feeling comfortable about, go back to the lectures that you can find on YouTube or feel comfortable contacting me directly if you have a question. Hope you have a great week. And again, thanks for staying with me today.
Thank you.
Thank you very much.
Thank you very much.
You're welcome.